pleasure and welcome.
Thank you for the introduction, and thank you for the invitation to come here and talk today. I do come from the State Serum Institute in Denmark and from the University of Southern Denmark, but I also come from the Bærent Health Project in Guinea-Bissau. The title of my talk was Assessing Real-Life Effects of Vaccines, but while preparing, I thought that a more appropriate title would actually be Assessing the Effects of Vaccines in Real Life, not only focusing on what are the effects of vaccines, but also how we use the vaccines affect their impact in real life. And the real life setting I'm talking about would be one like this: a small village in the eastern part of Guinea-Bissau, Guinea-Bissau being a small country in Western Africa. I will present some data on the effects of vaccines on child mortality as we assume they are, how these estimated effects are made, and using and presenting the assumptions behind them. I will then go on and present some of the real-life observations from the setting where I work in Guinea-Bissau, the data from there, and how these effects that we have observed contradict or contrast with the assumed effects of vaccines. And finally, I'll move on to what can be concluded from that, what should be the lessons we should draw from these observations, and what are the gaps. Under 5 mortality has declined tremendously over the past 40 years. 40 years ago, child mortality in Africa was at 20%, meaning that 1 in 5 children born alive did not survive to complete their 5th birthday. Over the past 40 years, this has been reduced a lot, especially in an African setting, where we are now at 1 in 15 children who die before the age of 5. It's still extremely high, but a progress has been seen. A progress which has been seen during the same time, and which is commonly also ascribed to which part of the decline in child mortality is also ascribed, is vaccinations. In 1980, we were at a global vaccination coverage of 21%, and today we are up at around 80%. And there's no doubt that vaccines can have and have had tremendous effect on child health. In 1988, when the polio eradication program was initiated, when the World Health Assembly resolved or made to eradicate polio, we had polio in large parts of the world. Today, we're down to polio being endemic in only 3 countries worldwide. And here, the African polio cases, the last case was seen in 2016 in Nigeria. So we're close to having eradicated the second disease after smallpox now due to vaccination. When it comes to estimating effects of vaccines on child mortality due to other infections, we commonly refer to the estimates by the WHO. I've copied this figure from the Global Vaccine Action Plan, and the estimate is that over a 10-year period, we will avert a total of 25 million deaths merely by obtaining the projected coverage targets with the vaccines already in use. A large proportion of this is ascribed to measles. So 11 million deaths averted from measles over a 10-year period. How do we estimate this number? Well, we estimate it based on coverage of the vaccines, efficacy of the vaccine given. So among those vaccinated, what is the proportion who are then protected against measles? And then in the absence of vaccination, what were the number of deaths we would have observed from measles? So for measles, the calculation could look something like this: 80% coverage, 85% efficacy of the measles vaccine, and then a 2.6 million deaths annually in the absence of vaccination, coming to something like 1.8 or in this calculation, coming to 1.8 million deaths averted from measles each year, merely due to vaccination. So with an 85% vaccine efficacy and a high measles vaccination coverage, we should see very few deaths due to measles today. And in this study by Liu and colleagues from a couple of years ago, there's indeed now a very small proportion of deaths being ascribed to measles. One death among 1,000 live birds are now ascribed through measles. So it does look really good. But it doesn't look good enough because we are still at a very high mortality, 1 in 15 in Africa as a total, and even higher in Guinea-Bissau, where I work. So to obtain the Sustainable Development Goal of reduction in child mortality below 25 per 1,000, we still have a long way to go. And what role do the vaccines play in obtaining this further reduction in child mortality? Well, in the study by Liu and colleagues, they estimate the number of deaths caused by different diseases. So in very low mortality countries and in very high mortality countries, and what lies in between. The conclusion from their paper is that in the Sustainable Development Goal area, what we need to do is prioritize the health interventions which we know are efficient in targeting the targeting the causes which kill children. That means we could work on either 3 of these, increasing coverage, expanding the number of diseases which we vaccinate against, or improving the vaccines we already have in use. And as I showed in the beginning, coverage has indeed increased. In low-income countries, coverage was at 10% in 1980, 21% globally, but much lower in low-income countries. And we are today up to close to 80% vaccination coverage. So coverage has increased. We've also increased the number of diseases we vaccinate against. In year 2000, Africa and Asia, most of Asia are marked in red colors, which means that they have 5 or 6 antigens in their vaccination program. Today, the pattern looks somewhat, or the colors are different. We are up at 8 or 9 antigens in the vaccination program in all of the world, or almost all of the world. So we've now come to 1 death per 1,000 live birds caused by measles, and similar proportion ascribed to tetanus and to pertussis, also 1 per 1,000, with the vaccines we have been using since the beginning of the vaccination program. We've implemented new vaccines against pneumonias, causes of diarrhea, and against pathogens causing sepsis and meningitis. So that should allow us to reduce child mortality much more. At least behind the desk, that's how it looks. In real life, we don't really know that much about how it looks. And we don't know that much because we base these proportions on estimates. The number of deaths caused by a particular disease is based on the product of the estimated proportion of death caused by that particular infection and then multiplied by the total number of deaths. This estimated proportion in a village which looks like this is connected with some uncertainty. How would you classify the cause of death of a child who presents with fever and convulsions and dies shortly after? Was that malaria? Was it meningitis? Or was it something else? So these estimates are commonly based on small studies in small areas, and then the findings are extrapolated to larger populations. The proportion are based on interviews, verbal autopsies conducted with the relatives of the deceased some months after death. So we have extremely big uncertainty in the estimated proportion. We also have a lot of uncertainty in the total number of deaths. Globally, only 35% of the births were registered by 1 year of age. Deaths are much more unlikely to be registered in the national statistics. A couple of years ago, we did a study in Guinea-Bissau where we conducted a survey among mothers who had given birth within the past 2 years. We found that only 16% of these births were actually registered in the national registries, and less than 2% of the deaths. So we don't have good national statistics for the number of deaths in low-income countries. Now, in Guinea-Bissau, we actually have fairly good data on the mortality rates, and we do so because of the Bandim Health Project. So Bandim Health Project, situated here in the capital of Bissau, is a research station. We perform demographic surveillance of a population in the urban area of around 100,000 individuals and of a nationally coverage sample of villages all over the country. We performed the surveillance by doing routine home visits to registered households. So first, a mapping out of the area and registration of all households. Then we register who lives in the households, and then we conduct regular home visits to all the households to follow up on all the individuals. So using a list of who have we already registered, who has been registered new, and then following up the status on subsequent visit. In addition to collecting information on vital status, so new births, deaths, we also collect information on pregnancy, which allows us to collect very accurate data on neonatal mortality. But we also assess different exposures and other outcomes than death, such as nutritional status. We assess uptake of vaccines, specific infections, and hospital admissions. And with a backbone of this, we've been able to produce mortality curves for Guinea-Bissau. So here, in the urban area, where surveillance has been going on since 1978, mortality has decreased from a mortality of 500 per thousand back in 1979 to around 80 per thousand today. Now, our under 5 mortality shows a lot more variation than the graphs by the UN system. Does that mean that we have much more uncertainty related to our estimates? It could, but the population we are following, especially here during the later years, is actually larger than the population followed in the surveys on which the estimates for the UNICEF data are based, so the UNICEF's mixed data. Also, there are points every year here, but there are not data points from Guinea-Bissau every year. So you would miss much of the fluctuation in these UN data. But the point was, what role does have the vaccines played in this reduction in child mortality, which is evident both in our surveillance data, but also in the UN data. So in the WHO figures, again here from the Global Vaccine Action Plan, we had 11 million deaths, or 10.6 million deaths averted through a 10-year period. Bandim Health Project was established when the vaccination program was still being rolled out in Guinea-Bissau. And in this vaccination program, measles vaccine has been part of the program since the beginning. Using the backbone of the demographic surveillance system, we have assessed the association between vaccination status and subsequent child mortality. So at a particular visit here, a child can be classified as vaccinated or unvaccinated for a particular vaccine, and through the subsequent collected data, we can follow up survival status. When this was done in year 2000, looking at data from the early 90s when the vaccination program was being rolled out in rural Guinea-Bissau, At time 0, children were classified as vaccinated or unvaccinated for measles vaccine, and they were then revisited 6 months later to assess survival. Here, in the blue line, you see the unvaccinated children with a lower survival than the measles vaccinated children up here. So being measles unvaccinated was associated with a lower survival. Overall, a mortality rate ratio of 0.48. When we censored deaths due to measles from this analysis, the estimates look very similar. Now a mortality rate ratio of 0.51. Now, it's an observational study, and though we adjusted for age and village cluster and other vaccines in this, it could have been something else. And that's, of course, a frequent comment, also made by us. It could be something else. So that's why we went on to do a randomized trial. A randomized trial in which the 9 months measles vaccine was still there, but at 4.5 months of age, we randomized children to 2 different arms, one following the normal vaccination schedule, and one receiving an extra dose of measles vaccine at 4.5 months of age. When children were followed up to 3 years of age, what we saw was that mortality was 30% lower among the children being randomized to an early extra dose of measles vaccine. 30% mortality reduction is unlikely to be explained by measles. And during this period, there were indeed some measles cases, but when we censor measles infections, we were still left with a 26% lower mortality among the early vaccinated children. So this does not correspond well with the number of deaths due to measles estimated by the WHO. On the second place in the number of deaths averted here from the Global Vaccine Action Plan is hepatitis B. But hepatitis B vaccine does little to child mortality. I will instead focus on measles vaccine given through supplementary immunization activities. So the measles vaccine was 85% efficacious. Therefore, it's recommended to give a second dose of measles vaccine so that you get a higher overall protection against measles. It's also recommended to provide this vaccine as part of campaigns, or it used to be recommended to provide it in campaigns in areas where you had low coverage of the routine measles vaccination dose, because through the campaigns you would be expected to reach more children who were not already protected through the routine vaccination program. So we conduct campaigns both to give children a second dose of measles vaccine and thereby increase the individual child's protection against measles, but also to reach the children who were left unprotected through the routine system because they were not yet vaccinated. We've looked at effects of measles vaccination campaigns in 2 studies. In a before and after study here in 2006, comparing mortality after a measles vaccination campaign with mortality in the same age group in the 2 years before. And we here observed a 20% lower child mortality in the year after the vaccine. After the 2012 measles vaccination campaign in Guinea-Bissau, we compared mortality of campaign participants and campaign non-participants again in an observational study, adjusting for different background factors associated with campaign participation and mortality, and we found 72% lower mortality among participants. A large proportion of this is probably explained due to residual confounding, but there's still something to be learned from these studies, because when we looked at the effects in both studies stratified by their routine measles vaccination status, what we found was that the children who benefited the most were not the children who had not received routine measles vaccine, but were actually the already vaccinated children. So the second dose of measles vaccine was estimated to have a smaller effect on child mortality based on the model we had, but the effect we measured here seemed to be much stronger among the already vaccinated children. So measles vaccines can have effects beyond the targeted infections, and they seem to alter the susceptibility to other infections. That's the only way I can explain the marked reduction in child mortality observed both in randomized trials and observational studies. And that fits very poorly with the model we have to estimate the number of deaths due to measles averted. So if the calculations for measles vaccine do not reflect the real-life effect, what about the other vaccines here in the vaccination program? In addition to measles vaccine, we've been investigating the effect of BCG vaccine. For measles vaccine, we could randomize to an earlier dose of vaccination. That's not possible for a dose which is given already at birth. But children who are born with low birth weight, that is a birth weight below 2.5 kilograms, are not vaccinated routinely at birth. For these children, it's recommended to delay their vaccination until they've gained weight and until they're presumably more immunologically mature. Therefore, we could conduct a randomized trial in low birth weight infants who were then randomized to receiving BCG at birth or to wait as it was currently done. When we compared mortality of children randomized to BCG at birth with mortality of children randomized to the normal delayed BCG vaccine, we saw in 3 consecutive trials among low birth weight children that neonatal mortality was markedly reduced, the meta-analysis indicating a 38% lower mortality among early vaccinated infants. Children do not die of tuberculosis during the first month of life, so prevention of TB explains very little of this, if any at all. Based on our verbal autopsies, with which a lot of uncertainty is certainly connected, the causes of death, which we seem to prevent most of, were the neonatal sepsis and the respiratory infections. So what's common for the BCG and measles vaccine, which both seem to reduce mortality by much more than we would explain based on the causes or the proportion of deaths which their target infections are associated with, is that they're live vaccines. The third live vaccine, which was part of the routine vaccination program when it was first introduced in Guinea-Bissau and many other countries, was the oral polio vaccine. And for oral polio vaccine, we've also observed beneficial effects both in observational studies and in randomized trials. In addition to being provided as part of the routine vaccination program, the oral polio vaccine has been given in campaigns. And these campaigns have been frequent over the past 15 years because we wanted to eradicate polio, and to eradicate polio, we need to increase herd immunity to polio. But at the same time, child mortality has declined markedly. When we assess in a before and after study, splitting observation child of each individual child under surveillance at the time of a campaign, comparing after campaign mortality with before campaign mortality, we find a 19% reduction in child mortality after vaccination campaigns. Oral polio vaccine campaigns are not the only campaigns which have taken place. Here with the dotted red lines, I indicated the vitamin A campaigns. If we perform the same type of analysis for the vitamin A campaigns, we see no effect of those campaigns on child mortality. If we do simulation study, putting the OPV campaign dates at random time points over the same period, we see no effect. So this 19% reduction in mortality, comparing the after versus before, seems to be specific to the OPV campaign dates. We've also looked at the effect of oral polio vaccine in a randomized trial, randomizing 7,000 children to BCG only at birth or BCG plus OPV at birth, and following them up to 1 year or subsequent OPV campaign. And here, again, we see a 32% reduction in child mortality among children randomized to OPV. So for several of these vaccines, so far presented for the live vaccines, we see effects of the vaccines which cannot be ascribed only to preventing their target infections. And they seem to alter the susceptibility to other infections. The last vaccine, which was in the vaccination program at the time when it was first rolled out, was the inactivated DTP vaccine, the diphtheria, tetanus, pertussis vaccine. What about this vaccine? Well, in a study which looked a bit like, or which looked exactly like the study which we did for measles vaccine in the beginning, again classifying vaccination status at time 0, following up children to 6 months of age. Here, among children between the age of 6 weeks and 6 months of age at the initial visit, we've looked at vaccination status and subsequent mortality. And with the lowest survival, you again see children who have not received the vaccine. In the red line up here, you see survival of children who have received a BCG vaccine. So they seem to be better off. But what's surprising here is the blue line. Children who had received BCG vaccine and diphtheria, tetanus, pertussis vaccine did not have better survival than children who had received BCG only. In a survival analysis, this came out adjusted for BCG vaccination status, cluster, and age to a 84% increased mortality after DTP vaccination. So we have a different observation for children who had received BCG, shown in green, measles vaccine here shown in blue, and DTP vaccine shown in red. That was the study from Guinea-Bissau, which I've shown some data from, but the patterns seem to be consistent across a range of cohorts. In cohorts looking at a number or several of the antigens in the same population, you see a consistent pattern with BCG and measles vaccine being associated with lower mortality, while DTP vaccine is not associated with lower mortality, and in many of the studies even with higher mortality. Therefore, it seems unlikely that a selection bias to vaccines should affect different vaccines in the same cohort so differently. So the real-life effects of vaccines seems to be that they have effects beyond the targeted infection. They alter the susceptibility to other infections. And we've termed these effects the non-specific effects of vaccines. So the effects they have beyond their target infections. These non-specific effects seem to be beneficial for the live vaccines that we have studied, but they do not seem beneficial for the non-live DTP vaccine. Now, how can we go on and study them? All children are supposed to receive both live vaccines and inactivated vaccines. So how do we disentangle the effect? Well, we can do that because the sequence of vaccines matter to the effect we observe. A child is supposed to receive BCG at birth, 3 doses of DTP vaccine with OPV at 6, 10, and 14 weeks of age, and measles vaccine at 9 months of age. But in this setting, that's not how children are vaccinated. Vaccine doses are delayed, and children end up receiving not only delayed, but also out-of-sequence vaccines. So here receiving DTP together with measles vaccine at 9 months of age. These 2 children, one following the top schedule and one following the bottom schedule, would be equally well off when we look at their specific protection after 9 months of age, having received the same antigens. But in reality, they're not equally well off when we look at overall child mortality. Comparing child mortality after 9 months of age when children were measles vaccinated, according to whether they had received measles vaccine only as their last vaccine in the sequence, or a combination of live and inactivated vaccine, we observed a 3 times higher mortality among children who were vaccinated with the 2 vaccines together. Sometimes the sequence becomes even more messed up, so that you end up receiving DTP after measles vaccine. Here we've compared children who were all measles vaccinated, first looking at if you were missing DTP3, so the third dose of DTP, it did not matter to child survival provided that you were measles vaccinated or compared with other measles vaccinated children. But if we went ahead and gave the missing dose of DTP after measles vaccine, we saw a tendency towards a higher mortality in these children. These studies are small, but they're not the only studies that exist in the area. If we take all the cohorts in which it has been observed, what's the child mortality comparing DTP given after measles vaccine with measles vaccine given as the most recent vaccine, we see a consistent pattern with higher mortality among children who have received DTP after measles vaccine, which in the meta-analysis come out to an almost 2 times higher mortality. So vaccines seem to have non-specific effects. They differ for live and non-live vaccine, and the sequence of vaccines is important. They also differ by sex. When we compare child mortality comparing mortality of girls with the mortality of boys among DTP-vaccinated children, girls tend to have higher mortality than boys do. 50% higher mortality if we perform a meta-analysis here. When we look at children who have received measles vaccine, the pattern is the opposite. Now the female-male mortality ratio comes out to a 40% lower mortality. Now, the vaccination program stipulates that children should receive DTP vaccine early in infancy and a measles vaccine after 9 months of age. And while some depart from this schedule, most would be vaccinated within those time intervals. So is this higher mortality for girls in this age window, lower mortality for girls and boys in this age window, just an age effect? Is that how mortality is by sex in early life? I don't think so. And to investigate it, you can look at data from the pre-vaccination era. Here's again data from Guinea-Bissau from the late 70s and early 80s, comparing mortality by sex between 1 and 8 months and between 9 and 17 months. And both in the urban area shown up here and in the rural area shown down here, we seem to have no marked difference in mortality of boys and girls in either of the age groups. If we go back to the randomized trial of measles vaccine I talked about earlier, we can compare mortality of children who were randomized in this time window to have measles vaccine as the most recent vaccine, or to continue to have the DTP vaccine as the most recent vaccine. And here, looking at mortality by sex, we see higher mortality for boys and girls in the control arm, but, sorry, that was the other one. Higher mortality for girls than boys here in the control arm, but the opposite pattern in the intervention arm, where children have received early measles vaccine. Now, we're no longer using DTP vaccine, so is this really a problem? In most of the world, DTP vaccine has now been replaced by the pentavalent vaccine, still containing the diphtheria, tetanus, and pertussis antigens, but also Haemophilus influenza type B and hepatitis B. And looking at children from the time of pentavalent vaccination after 6 weeks of age and comparing mortality by sex, we see exactly the same pattern for the pentavalent vaccine. Again, looking at children who have received measles vaccine now given together with yellow fever vaccine, we also see the same pattern as we saw for measles vaccine only. So higher mortality for girls and boys after inactivated vaccines, but lower mortality after the live vaccines. So in that study, we looked at vaccination, mortality after vaccination from pentavalent vaccine, the 73% higher mortality for girls and boys. In a supplementary analysis, we looked at survival until we registered, until children presented at health centers to receive their pentavalent vaccine. And these children are, of course, on average younger and therefore higher mortality, But until pentavalent vaccine, we did not see a higher mortality for girls than boys. So the effect does not seem to be explained by an age pattern. It must have to do with something else, and that something else could be the pentavalent vaccines. So vaccines have non-specific effects. They differ for live and non-live. The sequence is important, and they differ by sex. I have argued that these observations are important for child mortality, but they're not taken into account in the way that we currently prioritize health interventions. So many of the vaccines, or many of the changes in child mortality here, may actually be ascribed to, at least in part, to the vaccination program. For example, this drop coincides with the measles vaccine being implemented to be given to all children in the study area. We have a number of campaigns with measles vaccine and oral polio vaccines here in the later years. We also have a war here, which is, of course, nothing to do with vaccines. But to ensure that this child mortality keeps going down, if the results that I have presented here are actually correct, how could we apply them then to ensure that the pattern is what we would like to see? Well, if we are to use them correctly, a vaccination program which now looks like this, at the core it's still the same, but we've added some further antigens. Well, we should ensure that BCG is given early. We should ensure that measles vaccine is the most recent vaccine, or it's the last vaccine in the infant immunization programs, so that it profiles the immune system after the children have completed their vaccines. In rural Guinea-Bissau, that's not how vaccines are currently given. Using the data from the 182 village clusters here, we've produced a graph of vaccination coverage. The black line here is the BCG vaccine. And coverage for BCG vaccine only reaches 50% around 6 weeks of age. So children do not benefit from BCG vaccination early in life. Measles vaccine, the coverage does not reach anywhere close to 80% at the moment. And it's slow to rise, while number of pentavalent doses are much quicker given to children. So we can do a lot on the implementation of the vaccination program. But we can also make better programs. Maybe the program shouldn't look the same for boys and girls. Maybe we should not only specify what should be the vaccination program, we should also specify how do you deal with it when children then depart from the vaccination program. At the moment, we just give any missing dose later on. Are such changes about to occur? I don't think they're close. That's the program as it looks today. In addition to the vaccines given during the first year of life, more and more countries are now implementing a second dose of measles vaccine through the routine program. But a DTP booster dose is also recommended during the second year of life. In the future, what is going to happen is that we're going to remove the oral polio vaccine. This will happen as part of the efforts to eradicate polio. Oral polio vaccine is a live vaccine, and in rare cases, it can revert to a paralysis-causing vaccine. So to make sure that we stop having cases of paralysis due to polio vaccine, we can't keep on giving the oral polio vaccine. Instead, we're going to give inactivated polio vaccine. And we're going to give more of those doses, probably together with measles vaccine. And we are adding further doses of non-live vaccines during the second year of life. So through a pessimistic lens, I would say it's not self-evident that this decline in child mortality, which we've observed over the past 15 years, is going to continue. To know how mortality develops, we need real-life data on child mortality to be able to measure the impact also in shorter time frames, not having to estimate and extrapolate child mortality estimates to the extent that we currently do. There's no doubt that child mortality in low-income countries is still unacceptably high. But in the attempt to combat the high child mortality, there's been a push for action. We need to do something. And therefore, we need to do something. We need to implement the interventions which we think we know work. And we need to make sure that we obtain high coverage by them. We've not prioritized monitoring their effects. And the data we have coming out of Guinea-Bissau seem to indicate that these effects which vaccine can have on child mortality beyond the targeted effects are far from negligible. And then, in order to make sure that we actually see the effect of the interventions which we implement, which we hope to do, we need to keep on monitoring the effects. When we do so, we need to keep an eye on to when child mortality does not, when the patterns in child mortality do not change as we expected them to, because that's what may actually help us define the path ahead in order to reduce mortality. Thank you for your attention, and I'll be very happy to answer questions.
Yeah, thank you. I guess there will be many questions, actually. I just want to go with a microphone so everybody can listen to the question. So just wait a second that I reach you with a microphone. Okay?
Thank you, Ane, for a very clear talk. I have a question. You showed that the oral polio campaigns, they were associated with reduced mortality. And you showed that the DTP vaccine was also, if you, when you received that, you also had a higher mortality.
Yeah.
Did you look at whether you got DTP alone or together with OPV?
Yeah. We have they're normally given together, and that makes it difficult to disentangle the effects completely. There have been frequent stock out of vaccines in a setting like Guinea-Bissau, and when we look at periods where DTP has been given without OPV, it appears that the effect is actually worse. We are just now starting to look at a stock out which took place some years ago, but trying to use that data to look more carefully into effects of OPV given with DTP versus DTP alone. So there's some observational data which indicates that OPV may have ameliorated some of the negative effect of DTP, and we're still investigating that further.
Thanks.
Jan van den Broeke, thank you very, very much for this overview about the topic that, as Lorenzo indicated, is mostly lacking for in this course. I mean, to increase my own understanding and maybe understanding of other people, I would like to know, to ask you, more and more people are vaccinated, but what drives ultimately whether a child is vaccinated? Who is the ultimate decision maker? Because that differs from country. Is it the mother, the father, the grandmother, the mother-in-law? Does education play a role? Does wealth or rural, urban play a role? Are there characteristics of the people who never get vaccinated? I mean, this is outside, say, a little bit of the beautiful demonstration that you gave in the data, but it's just to increase my own and maybe other people's understanding about the sociological part, so to speak.
Yeah. I think the decision maker here, it depends a bit from ethnic group to ethnic group who gets to make the decision regarding the care of a child. But the mother is the decision maker on taking the child to vaccination. In most of the groups, we do have some where she certainly it has to be approved by the father before she will take her child to vaccination. We do see urban-rural differences in vaccination coverage, and there certainly is also higher vaccination coverage among educated children of educated mothers. I have mainly been looking at determinants of vaccination from a confounder control perspective. And there I think it's very important that there's no difference in vaccination coverage between boys and girls. So I can't explain the differences in male-female mortality by different vaccine-seeking behavior. Also, I think it's very important that different antigens have different directions of effects. So if there's if it's just the compliant mothers who otherwise would seek health system or health service for their children who would seek vaccination, we would expect that any vaccine would be associated with beneficial effects. But since we have very different effects for different antigens, I think the background factors associated with seeking vaccination can't explain the effects on their own.
Thank you very much.
Thank you for a very interesting presentation. I live in UK, and here I see that there's a decline in uptake in measles vaccinations, and we have outbreaks of measles now. What is your view on this, and how can we convince mothers in UK to take up or get their children vaccinated? The other question is about your methods of analysis, and I wondered whether you have been looking into some of the self-controlled analysis, because you may be able to overcome some of the issues you have by confounding of the individuals.
Yeah. So I think, first of all, I think using the data I have presented today to convince mothers in the UK or elsewhere in Europe to seek vaccination may not be these may not be the most convincing pieces of evidence. But we've actually taken the findings back to Denmark and used the Danish registries also to look at vaccinations association with hospital admission for infectious disease. And in Denmark, we also see lower admission rates for infectious diseases. We also, in line with the studies here, see it particular for lower respiratory infections. So the same morbidity patterns which we've observed in Guinea-Bissau as causes of mortality, but the measles vaccine having effects on the same morbidity patterns. I can't say pathogens because the data from Guinea-Bissau is not sufficiently specific to look at particular pathogens. Regarding self-controlled case studies, no, I haven't been looking at that. And it's certainly something we could look into. But my understanding is you also need very precise information about vaccination. My problem is that for some of these cohorts, I know the vaccine from the day it's given. For other cohorts, I can only start my analysis by the time I register when a vaccine is given. And therefore, I might miss out on important time windows in which to look at vaccine effects using other methodologies. But it's certainly something that it's worth looking more into. Thank you.
Yeah. Christina van den Broeke from the Netherlands. About the measles vaccination and the BCG, I was wondering, you have been correcting for a lot of confounding. But I missed whether you looked whether the measles vaccine was given in children that had BCG before and then measles. Because it, as you showed, BCG is protective for much more than just, being BCG. And this has now already been also demonstrated experimentally in animals and in the lab. It's known that BCG increases innate immunity and cytokine production, and that the effect is rather long. So I was wondering whether that also affects in the long run when you vaccinate for measles.
Yeah. The early studies, so the marked decline which occurred in child mortality from 79 until the subsequent year, this was a completely unvaccinated population, also unvaccinated with BCG. And you see among vaccinated children, mortality drops to 1/3 in the subsequent year. Mortality in unvaccinated children looked more similar to the prior year. So I don't think the effect of measles vaccine is conditioned on the BCG vaccine, but certainly the immunological studies coming out about BCG vaccine, especially from Nijmegen, looking at programming of monocytes and epigenetic changes induced by BCG indicates that we may be getting closer to an explanation why BCG vaccine works as it does. I don't think we are yet as close to understanding why does measles vaccine work as it does as we are for BCG.
And could it be indirect, because having measles reduces overall immune status? So after measles, there is a period that the child is more sensitive to other infections?
Yeah, there is a period where the child is more sensitive. And I know the MENA study, which came out some years ago, looking at ecological data and also talking about immune amnesia for an extended period of time after. But what we see in data from Guinea-Bissau is that children who have survived measles infection, so on an individual level data and level, with using individual level data, it's not the children who have had measles infection who have higher mortality in the period after. So that sort of contradicts the conclusion MENA draws from the ecological data.
Thank you so much. I'm David from Uganda, and I identify with most of the presentation. My question is with the schedule you proposed. I'm wondering why you would, the BCG timing, you still recommend it at birth, and yet, based on the previous speaker, and there could be benefits if we introduce it late because of the improved immunological response. Yes.
Yes, so when you measure specific, TB-specific, so interferon gamma or other responses to the BCG vaccine, yes, you do see better response if you vaccinate later. But all our data on early vaccination indicates that it protects better against other causes of death, or it can only protect after you give it, and the mortality is particularly high during early life. I did not present that here, but we actually see an effect already within the first 3 days after BCG vaccination. So you would miss out at the expense of trying to wait to get a better response to the TB or better TB-specific response. You would be sacrificing or missing out on some beneficial effects on all-cause mortality by waiting.
Would the booster dose help?
Maybe. In one study, we've tried to give a booster dose of BCG at 18 months of age. And among children who did not receive a non-live or a DTP booster dose afterwards, there was clearly, there was a strong beneficial effect. I think we need more data on whether a booster dose would help, but I think it would be worthwhile investigating, absolutely.
Thank you for this very interesting talk. I think you mentioned stockout situations that were quite frequent, and I was wondering, what do you see as the main reason for the poor compliance with the prescribed schedule? Would it be the supply situation, or is it like behavioral patterns on the side of the population?
Okay, I can't shift the slides here, but I think some part of it is certainly seeking vaccination, but BCG vaccine is given in vials containing 20 doses. If a mother shows up at a health center to have her child vaccinated on a day where there's just 1, 2, 3, 5, 6 children to be BCG vaccinated, she's told, sorry, if I open a BCG vial today, I will throw away the other 14 doses of BCG vaccine, so go and come back another time. And I think that is one of the main explanations that BCG vaccination coverage at birth is so low. So we, of course, trying to say, well, the vaccine you spend, the vaccine is relatively cheap, and the time the mother spends going to seek vaccination and going back home is actually of the same magnitude, or the value of the time and the money she spends on transport is about, it comes to about the cost of the vaccine. So you try to save vaccines by saying, okay, go back, come back another day, or try to save resources. And it's not cost effective when you take into account also what the mother spends. So part, yes, it has to do with poor healthcare seeking behavior, but that's only part of the explanation. A lot of barriers also exist on the service providers.
Nina Künzli, Anna, thanks a lot. It was a fantastic talk. I think one of the bottom line messages, take-home messages, it's far more complicated than we might think. The sequence matters. It matters maybe even sex, and it matters what we vaccinate and what not. So my question is, where does the discussion stay, more on a global level or more on a country-specific level beyond Guinea-Bissau? Because, as you know, in some countries we don't even give BCG anymore at all, but it seems to matter in your case. So where do we stay in optimizing and fine-tuning and stratifying the vaccination strategies by sex, by type, by sequence in a global context?
I think we still stand on two mountains trying to get the message across. We are very far from getting, I think we are further from getting these findings implemented into program than I hoped we would be. I think part of it is that I might be able to take this to the EPI program in Guinea-Bissau, and I can show them, look, we need to open a BCG vial for one child. This I can measure, I can tell you how many wasted opportunities do we have, but the program is not being evaluated by what's the coverage by 1 month of age. The program is being evaluated by what's the coverage by 12 months of age. So there's no incentive on the program to try to reduce the age of vaccination for BCG as it is now. Programs are not made locally in Guinea-Bissau. They're made by the donors. And Guinea-Bissau funds a small part of its vaccine itself, but the majority comes from elsewhere. So that's where the priorities are set. So I think if we want to impact the way the vaccination program is implemented, it's the donors and the WHO which we need to reach. And I think we still have some work to do in getting our message through there.
Okay, we have one question more. Actually, you raised your hand, and then we can finish the session. So you are the last question.
Thank you, Anne. A really great talk. Just a brief question. If you could rewrite the equation that WHO is using to estimate the benefits of the vaccination, how would you do that?
I don't think I would use an equation to describe the impact. I think I'm calling for more and more. We need real-life data. We need data from the settings. So you see, well, the effect of measles vaccine, yes, it's associated with reduced mortality, but only as long as we don't provide an inactivated vaccine after the measles vaccine. And there are so many changes being implemented in the vaccination these years. Comes in campaigns. All of a sudden, now we are implementing MenAfriVac, so meningitis A vaccines all across Africa, or not all across Africa, but across the meningitis belt of Africa to combat meningitis A. And surely we need to do something about meningitis A, but it happens with no consideration of what does that do to all-cause mortality. So I don't think we can put it on a formula. I think we're still disentangling what sequences are the best sequences. And I do think we need continuous monitoring to know that we are on the right track. Maybe we need a large-scale trial trying to compare what we think is the better program rather than specifically. So we need something which is operational at scale. And I think that was my point in trying to change my title from real-life effects of vaccines to effects of vaccines in real life, is how do we operationalize these findings? And for that, I think we still need a lot of evidence because the setting we implement in keep changing. So no simple formula can describe it for the knowledge we have right now, at least.
Okay, thank you. This was really great. Thank you for your presentation. We can gather outside to take the picture, just outside this room in the terrace here. And then will be the coffee break, unless, Neil, you have to announce anything. No, so we meet outside for the official photo.